my goodness! Look at you. That's a nice little rosy red cheeks right now.
I know. It was hot out there.
Was it from there or like
in the waiting room?
Oh,
There's
I didn't
a
know
lot
if
of people.
I didn't know if it was from like the mask or anything today, or they did it.
I don't know.
He's got
definitely.
He does have eczema now.
Yeah. Okay. How you been?
You tell us.
He looks good. The MRI looks good. You know, some of that flare that we're talking about, it looks less prominent to me today than it did whatever the last one. So definitely not worse.
Got my heart going.
The resection area, like, so just the. Where are you trying to get to? Okay, I'll move. All right, I don't know. Okay, no, he's good. I got him. I got this. I know.
I want to open the door.
He just goes.
Okay.
I want to open that door.
Woo! The resection cavity itself is a little bit bigger, but it doesn't. I don't know if that just kind of comes and goes. Like, it's an empty space, so you know, it doesn't. Like, I didn't see the brain shifted over or anything like that. I'm asking. I texted the radiologist just to see if she agrees with my assessment of it.
Mm-hmm.
I didn't see anything I was worried about, so I mean, it looks good to me. I think some of that flare signal that we showed. I can. You want me to show you?
Yeah.
Sure. But just the. It looks smaller to me. So again, we weren't sure if that was just like post-surgical. All right. How's he been? Good.
Yeah.
Good. Any seizures or anything else?
Not that we have
Oh, good job, buddy.
No.
Come here.
Okay, here. Why don't we do this?
Right.
Ha
There you go.
I'll outsmart you.
Hey, look how fun this is, though. You can move this around. James, look. James, look.
He's like, no, that's not what I want.
Yeah.
All right, let's see if we can. And I know you saw Dr. Reddy probably in October. I read through and sounds like
Yes.
she's pretty good with where the doses are. And stuff
Yeah.
like that, so.
Yeah.
What's up, sir?
Hey.
Where are we going?
Can you not stop?
That's okay. I'm fine with it. She's want to make sure I don't hurt him. As long as he doesn't, nothing happens to him, he's good. We're good.
Do you want to look at the picture?
When it comes out, thinking your picture may show up right when it comes out.
Okay.
It looks like he's walking well and doing all that.
Motor skills, incredible.
Yeah.
A little behind on verbal.
Okay.
That's fine.
Yeah. And I think Dr. Reddy and I agree. I mean, Tennessee early intervention, just to kind of see if they would think about anything for him.
We just had some early intervention 2 weeks ago. Some lady came out and saw him,
Yep. Good.
That's a lot of questions.
so we're gonna start that.
And Naftal did his surgery, or was it?
Yeah.
Yes.
Okay. All right, that's not what I wanted to see. Let's take this first.
It spins.
Very exciting. That was big.
Before. So we looked at before, you know, I think we were talking a little bit about like some of this marking around here and there. Now this is without the contrast. This is the flare. So this is going to pick up all the, so now when you look at it,
Of course, your phone's not. Whatever.
tell me where you want me to stop.
No, you're
Keep-
fine. I'm
keep
just
going.
videoing now.
Oh, you're
So, like,
videoing.
Go back, sorry. So, actually there.
Like this?
Like that.
That-
Why- that
Oh.
looks bigger and brighter to me than...
Yeah. I think it's that you're getting the confluence of vessels, so right there. So,
Okay.
and it's not like a nice round. Oh, hey. Sorry, I was not
He loves a
expecting.
butt grab.
That's okay.
And he's laughing.
He's fine. I was not ready for that one. That's what threw me off a little bit. I didn't realize he was that
It
close.
just does look a lot bigger.
Yeah.
So I'll ask him if there's anything to do with it. I mean, again,
There's no way that like we wouldn't see something.
yes, there's no way that I would assume with, especially with nothing clinically with him, he's not having like this thickness here compared to there.
That looks smaller.
Yeah, I don't. But then this itself is
Oh,
wider.
yeah. It looks bigger.
And the heads are different sizes on this, but even when you get that, it looks like it's like about a centimeter.
Interesting.
So, but again, this is an empty space. That's not tumor, right? So it's just, I don't know if just the way that I mean, there's going to be some fluid in there. I mean, I'm happy to ask Dr. Nassel about it. I don't think we would do anything about it. Like, if you try to go in and, like, it's an empty space, but there's going to be fluid in there. It's not just a black hole, right? There's going to be something in there. But if you took out that fluid, your body's just going to put it right back in there. You know, like, there's not a, you know, and the one thing that I can ask him about is, you know, we have, like, you see how this line kind of goes down the middle?
Yeah.
I can ask him to look. It doesn't look, I mean, it's still not perfectly centered, but I think it's always been like that. But, like, you know, nothing that, like, with how he's looking and everything, like, you worry that that area is just getting more and more fluid. If it's pushing things over, kind of changing kind of where the midline is for him, then you have to think about, like, is there a reason to, like, do something else with this, like a shunt or something like that. I've only seen one patient that I've had that had to do that, and they had a lot more marked kind of thing. But I can ask him about that.
What's the brightness on the left side? Yeah, like what is that?
That's part of the. So he's got a little bit of another fluid collection in here. I think that's a little bit of an artifact from the actual MRI. I don't think there's like something floating in that fluid.
Okay.
I think it's just the way that the MRI magnet's sensing the fluid that's in there.
So definitely not a tumor.
No, that wouldn't be, because it's not like a solid mass kind of.
Got it.
Now, when you look after the contrast, so he's always got this nice little ring around.
Mm-hmm.
Of course, because that's just kind of, you cut, and that's like the scar tissue kind of healing. Oh, I know. Who did it?
Uh-oh.
Yeah, so we try to track that line all the way around and make sure that in terms of like thickness and everything, like it's thick over there, but it's still about the same. I don't know if he's moving a little bit on this. Let me see if let's see if this one's better. There's always two different contrast ones.
Very little monster.
So, you know, what we're looking for with this one is that, you know, this rim is going to be there always, because that's the scar that they, like, what I'm worried about is if something is kind of jutting out, you know, 3 to 4 times the thickness of this, because that would be, if it's not as, like, nice, like, even rim, you worry that that's like a tumor that's kind of sitting at the area. And that again is going to be the primary area that we're going to kind of course we're looking at everything else, but the biggest risk is just right around that area. You worry that as much as they try to do everything, that is there something left behind. You know,
And that area looks the same.
It looks the same. Here, let me link them up so that we can kind of go all the way through together. That's a good spot. Okay. Symptoms. So
Right.
we didn't think it was tumor. It's that you have an empty space, and depending on how prone it is to fill with fluid.
What is a shunt?
A shunt would actually be a
Drain.
surgical procedure where you put the shunt and then it gets snaked underneath the skin all the way through, and it empties out into the belly. Because that's we typically do it for patients who have hydrocephalus. So he didn't have that, but the ventricles, if they're really big, like these things, which he doesn't have. But for some patients, for many reasons that they can get that, it's a way of diverting the fluid. And so, and it's a completely sterile thing, so you can just empty it out into his belly, so like the abdominal cavity. So not actually into his like stomach per se, but you know, you have empty space in your abdomen.
Right.
It just floats in there, and then the body just reabsorbs it. So yeah, it's kind of cool. We do it all, like they do it all the time.
I remember you guys telling us about it when he was first.
Yeah, because he thought, but that was more for the ventricle itself. This is not a ventricle thing. It's just the kind of the fluid there. I don't know how much it will do for that, but again, I don't do the procedure, so I can ask.
What about the line on top?
This?
No, like here. What is that? That seems like a new line.
I wonder if there's just a little bit of a, like, since it's a fluid area, like, let's see, like, it was right over here before.
Mm-hmm.
And so,
Interesting.
I don't know if it's just that there's, I wonder if there's different levels of fluid in there, and that's what you're just seeing based on how he's kind of
Like,
positioned. Yeah. It's not thick enough. Sometimes, like, some people develop, like, septates, like, so, like, this, if there's a fluid in there, there's, like, different compartments of it, but it's usually a lot thicker than that. I think that's more artifact, because there was something there before that went away, and now we're seeing something. So I think it's just it's those kind of bright lights that you're seeing in the fluid. It's such a bigger amount of fluid than typically, so I don't know if the MRI is just not catching it well. But what I do feel like, I mean, that line looks like the area around it looks good. The flare doesn't look different. He's been doing great.
Yeah.
I think I'm pleased with it. So the other thing I will do is I'll ask Nathal, see what he thinks about that.
And radiology also already saw it, or are you waiting to hear?
I'm waiting for them.
Okay.
Because just I know they're going through the process because someone else got an MRI earlier today and just got their report. So I think he's in the line. I know that because they just go through as soon as they get him. But the trouble is that all my patients I take up the MRI scanner.
I'm sure you do.
I literally do. Like every patient goes there and then comes to see me. So I have like four or five that go in an order. So they know when I'm asking about things because it's just the next person I'm seeing. So
have you seen any more
no
oligodendrogliomas this year?
Nope.
So he's just the special one.
He's the special one, but he's really special. He's been doing awesome. What are we? What, a year out? More?
We're almost a year out.
Yeah, February.
Okay.
February will be a year.
Wow. Okay.
So what does it mean, like, big picture? Are we still in cancer limbo? Do we graduate into remission?
I would say he's in remission right now, but he's still observed.
Mm-hmm.
I mean, I think it's that idea of, like, we're not seeing anything. Like, I would assume that if there was a large residual tumor, like, even if that's something we could see, it should have grown by this point. I mean, we've kind of doubled how long he was alive, like, versus like since we've done, right? I mean, he was only like, how old was he? He was like 6 months, and he's gotten almost a 6 times 2, and we're not seeing something. So I mean, I think it's a really good sign. I'm gonna really go cautiously about how often I spread these out. I think I'm still gonna go slow with that. Just knowing.
Yeah.
Because I also know that if we can catch something early, that we have multiple interventions that we can still do, even if it's reasonable. I think if something showed up again, I mean, we'd always still think about, like, let's just see surgery, even a possibility again. And then do we then do radiation on the back end of it? Like, I think for him, why I'm going to be really close about watching him and all that is because I feel like there's a lot of things that we could do if we saw something.
Right.
It's not like we've exhausted options for him. I think we've actually saved a lot of options for him between the kind of some of the mutational things and the targeted stuff, the radiation, surgery. I'm hoping we don't have to do any of that. But I do feel like if anything ever came up that we were like, okay, well, this is something we have to, like, do more treatment for, I think he's in the boat of, like, having a lot of options versus not someone who's just like, okay, well, we saw it, we can't do anything.
Based on what, I guess, little or most we know about the type of tumor he had, does the longer he not have one make him more likely to get one again because they come back? Backwards? The longer he goes, the less likely?
Yes.
Okay.
Because it's not...
like a clock that resets.
Yeah. Because it's the idea of not that he would get a new one, right? It's the fact of, is there anything that was residual that will grow, right? It's almost to say, like, if he had a new, like, there's nothing about him that makes us think, okay, well, he's going to get the same thing over here, and that's going to be what we call, like, a de novo kind of mutation, right? Like a de novo. It is, even if it's, 6 months out, a year out, or whatever, it is because something was left behind, or there was a cell that kind of was floating around that maybe was within this area and then started growing again, right? And so for something that's a high grade, a grade 3 anaplastic kind of thing, they by nature are going to grow quicker. So they're ones where I would have thought that usually within the first 6 months he would have declared himself. I mean, that's what I think. 6 months was a big thing for me, for him, like, because just the nature of it, like, that's how quickly it's going to grow. So, not saying that we don't keep an eye on it, but the fact that we were getting almost pushing a year on him without doing anything is a very good sign, because just the nature of this type of tumor, based on everything that we saw with it in terms of its pathology and the type of tumor it is,
Careful.
and just historic, like, they'll let us know within 6 months, especially because we kind of did the surgery and just observed him afterwards. Like, there's not anything else that, so the fact that it hasn't come back is a really good sign.
Is he more predisposed? I guess this is kind of asking the same question twice. Is he, like, in my understanding, for cancer to happen, there has to be like certain conditions met and the body not catching it?
Yes. Do you think, like, is he more prone to developing something else, like leukemia or lymphoma?
Not necessarily, but just like his body didn't catch it this time, is it not going to catch it the next time?
Well, one of the things, and this may be important for you guys as well, and I'm not trying to ask you something that's personal or whatever, but I think the other thing is, like, if you're thinking about having more kids, one of the other things that we could do at this point is, even though this is not something that is, like, we think is something inherited from him, we have a group of people here, we call them cancer genetics, and so some families will want to know that just because he was so young, maybe something that's not as common, is there something that makes something in the family that's more prone?
Right.
I don't hear anything else in the family, like, I know, like, if people will develop colon cancer, people will develop breast cancer. What we're looking for is the kind of the abnormality, like, family members who develop breast cancer in their 20s, colon cancer in their 30s, having, not this type of tumor, but there's certain types of, other types of tumors that we see in kids that make us think it's something more predisposed, and it's not even this type of anaplastic oligodendroglioma, but they're like certain type of kidney tumors that you only see in families where there's like this cancer predisposition.
Okay.
I'm happy to refer you over if that's something that you would like to know.
Probably.
No, and I think it's great. I mean, I think that's fine, and I think especially I've seen that with families where, he's young. It was a lot of stress on you guys appropriately, not knowing. And again, I'm not making you have more kids. This is your decision. But like, I think it puts it kind of burdens some people of, do we want to go through this again?
Right.
And especially if I can't tell you, like, okay, well, 100% for sure this won't happen on the next kid.
Right.
I'm never gonna do that because I'm a lawyer.
Lawyers exist.
Yes, but you know what I'm saying. Like, I think the idea of having someone like Cancer Genetics at least kind of do their evaluation, think about it. They may even just talk to you guys, see you guys, and say, there's nothing that we know about, there's no reason to send additional testing, because sometimes we'll send it based on just family history. They'll go through, think about it, and do all that. And I'm happy to refer you guys over there, just so that you guys can kind of think about that. So in case you're thinking about having more kids, or even just trying to think about for anyone else in the family, it would be, you could definitely meet with them.
Last question you probably already answered, but with you talking about a cell that probably isn't floating around, but would it be strictly stuck to his right temporal lobe, or could it be spine? Could it be brain?
That's why we do that. That's why we do brain and spine.
Okay.
So, but the interesting thing is, like the oligodendral, like any of these kind of cells typically don't go outside the brain and the spinal fluid, right? So that's why we're doing that every time. And for him, because it's a anaplastic, kind of the higher grade, we will do a brain and spine every time.
Yeah.
Because of what that idea of that the highest risk is in this area, but I can't 100% say that that's the only area that we have to look at.
Okay.
There's some of the lower grade tumors, like the grade 1 kind of things, that we still watch, like a regular oligodendroglioma often can be a grade 1 kind of thing. Them, I would only do a brain MRI. Like, I don't do a spine MRI on them, because we know that it's only going to occur in that area. We'll still watch it, probably pretty similar to what we did to his, but then the MRI just gets a lot easier because it's a shorter MRI because it's the brain. But given the nature of this, we are watching both this, but that's what the spine MRI is, and I honestly have no plans of cutting out the spine MRI anytime soon.
Okay.
So
last question. When you were reading about it, it's mostly older patients that have them, and they mostly came back. Is that because it wasn't completely resected, or they still had stuff floating around, or?
It depends.
I know you can't. Broad strokes here.
Good. I mean, I think the one thing that's always a little bit harder is, some of the, even though they're called oligodendrogliomas, like I know this with other types of brain tumors too, is that the biology of it being in a 6-month-old versus an older person is a little bit different.
Okay.
You know, and so some of the mutations that you see in the adults, they don't get, and a lot of it's probably driven by that. So even though under the microscope it all looks the same, we think that a lot of these tumors molecularly are different in like a pediatric patient than an adult patient. And so I think it's sometimes very hard, and we don't do this as much as like extrapolate what happens in the adults, the peds, because they're just
so different.
It's a different kind of just environment for them for some reason, and just something with what is causing the tumor is different for them as well.
I don't want to think
No. You know, I always answer your questions.
I know.
So.
That's all the questions I have too.
So I mean, I think we'll probably did we do what 4 months this time?
Yes.
Yeah. So we'll keep on that right now. We'll do the next one in 4 months.
Cool.
We'll definitely let you know. Yeah. So the 2 things for me to do is I'll ask Naftal to look at this, just to make sure that he doesn't think anything different, and then we can refer over to Cancer Genetics. It'll probably be a few months. It won't be something that's like right away. No, I'm just saying, but yeah, and it's somewhere here on the Vanderbilt, and I know you guys are fairly local to here still, right?
Yeah,
So,
I think we